Greetings from Jabalpur, India. Today we'll discuss hemifacial spasm and its mimics. And we all know that hemifacial spasm is not a very rare disease, and it often comes in neurology and neurosurgery OPDs. And many times the decision for surgery is taken for it. So we should all be knowing how hemifacial spasm is diagnosed and what are the differentials of it to prevent any unwanted side effects. So I have taken all these videos, the coming videos from this book, which is Principles and Practice of Movement Disorders. And it's a very excellent book. There is no financial disclosures. But I recommend this book to all people who are having interest in movement disorders. So hemifacial spasm is a paroxysmal involuntary unilateral twitching of face in 98% cases. In less than 2% cases, it may be bilateral, but it's never simultaneously bilateral. This is more common in females, and it is precipitated by doing sustained voluntary contractions. If you ask the patient to do sustained contractions, the hemifacial spasm will be precipitated. It usually begins around the eye and then it spreads to the rest of the face. And very importantly, the eyebrow moves up in this condition. That is because of the frontalis taking the eyebrow up. The hemifacial spasm can be of myoclonic variety, it can be of tonic variety. So in myoclonic type of hemifacial spasm, in this video, you will see there is twitching of eye. There is mild twitching of the oris muscle also. And if you look closely, the eyebrow is moving up. The hemifacial spasm can also be of dystonic type, in which there is dystonia of the muscles of eye. But again, in this patient, you will see that the eyebrow is moving slightly up from the contralateral eye. So this was hemifacial spasm of dystonic type. So as I said, in mild cases of hemifacial spasm in which you have doubt about the diagnosis, you can ask the patient to do sustained contractions. Here, the right eyeball is mildly twitching, but as you say the patient to do sustained contractions, here, sustained voluntary contraction, and then the hemifacial spasm will get precipitated now on the left side. So that's a classical sign of hemifacial spasm, which is precipitated by doing sustained contractions. Now, the other characteristic sign is other Babinski sign, in which there is elevation of the eyebrow. In the normal Babinski sign, which is the extensor plantar response of the foot, here the eyebrow is elevated. This is known as other Babinski sign. And this is also characteristic of hemifacial spasm in comparison with the blepharospasms. In the blepharospasms, the eyebrow goes down. In hemifacial spasm, here you can see the right eyebrow is going up compared to the left eyebrow. The patient also signals. Here you can see the right eyebrow is moving up. The hemifacial spasm can be divided into primary and secondary. The primary hemifacial spasm is commonly attributed to vascular loops compressing the seventh cranial nerve at its root exit zone. And secondary hemifacial spasm is labeled when the HFS arises due to facial nerve damage produced after Bell's palsy, tumors, demyelinating disorders, or trauma. This study compared primary and secondary HFS patients and found that the difference mainly is in the clinical scenario. Most patients, that is 65% with primary HFS, initially had contractions of periocular muscles alone. The contraction starts around the eyes. Whereas most patients, 72% with secondary HFS, report involvement of the upper and lower facial muscles simultaneously, including the platysma muscles. There are many differential diagnoses of hemifacial spasm, like hemimasticatory spasm, in which there is spasm of the masseter muscles because of irritation of the trigeminal nerve. There can be myoclonus of the face, which is generally bilateral, and it is relieved with clonazepam. There can be blepharospasms, which is again bilateral, and in that there is closure of the eyelids and the eyebrow comes down. In the oromandibular dystonia, there is dystonia of the oral muscles and mandibular muscles. There can be craniofacial tremors, which can be relieved with the drugs for tremors, and these tremors can be also mildly suppressible. The facial chorea is a part of the systemic abnormalities and often a part of Huntington's chorea. The patient may have tics, which again can be bilateral, and they can be associated with the neurobehavioral problems like OCD, impulsive behavior, ADHD, and this can be a part of Tourette syndrome, which is hereditary. There can be facial myokymia, in which there is vermian-like movements over the face. There can be tardive dyskinesia. There will be history of antipsychotics in tardive dyskinesias, and there can be psychogenic variety of hemifacial spasms in which there is bilateral from one side spreads to one side to the other side, and doing sustained contractions doesn't precipitate hemifacial spasm. In fact, it can relieve the hemifacial spasm. So all these things can be distinguished using the electrophysiology, and MRI will also helps to diagnose any neurovascular conflict or tumors, etc. So this is an example of blepharospasms in which you can see there will be contractions of the eyelids, and the eyebrows are coming down. This is bilateral, and there is hardly any closure of lips. The facial tics is a neurodevelopmental disorder. There is presence of motor tics and often associated with phonic tics. There will be neurobehavioral problems associated like OCDs, impulsive behaviors, or ADHD. And this may be a part of Tourette syndrome, which is hereditary syndrome. You see bilateral facial movements, one side to other side. So the phenomenology is very important. And if you have doubts, you can advise electrophysiology studies, which can also differentiate it to be a bilateral problem. The psychogenic hemifacial spasms is alternating. You see right side sustained contractions. And now a patient has left-sided sustained contractions. And if you advise her to do some voluntary activity like sustained eye closure, the patient will have abolition of contractions. Faciomasticatory myoclonus is a bilateral asymmetric facial myoclonus that can be associated with masticatory muscles, pharyngeal muscles, axial and limb myoclonus. And it's a slow rhythmical myoclonus. It's seen in Whipple's disease, which is a bacterial problem. The electrophysiology studies will confirm the origin of myoclonus and often pontine region. And this type of myoclonus, this continues in sleep. Compared to oculopalatal myoclonus, the faciomasticatory myoclonus is much slower. So you are seeing a rhythmical myoclonus. So again, electrophysiology studies will help to differentiate it from hemifacial spasm. Coming to the causes of hemifacial spasm, this is most commonly because of a neurovascular conflict at the root entry zone of the facial nerve, and the vessels involved may be ICA, PICA, or sometimes vertebro-basilar arteries. About 4% of cases are associated with the tumors like epidermoid tumors, which are irritating in nature. There can be two hypotheses. The nerve origin hypothesis, in which their discharges arise from the region of demyelinated nerve, which is at the neurovascular conflict zone. And there can be ectopic discharges arising from that zone. There can be ephaptic transmission, which means transmission from the two demyelinated nerve axons. And this is the reason why there is involvement of much of the face. And this hypothesis was given by Kamiyama in 2016. The ephaptic transmission is also responsible for the trains of activity after single stimulation. As the disease goes on, there will be changes in ions, and that increases the nerve excitability. The facial nucleus hypothesis says that the peripheral neurovascular conflicts that leads to hyperexcitability of the facial nucleus. And this is shown by the hyperexcitability of the corneal or blink reflex, which is associated with the hemifacial spasm. The treatment of this condition is initially with Botox, and this is often preferred by many patients. But if the patient is medically fit and can undergo surgery, the microvascular decompression can lead to permanent cure of this condition. The Botox improves the symptoms in 85% of the patients, and this is applied in multiple muscles around the eye, zygomatic region, orbicularis oris region, and mental region. In the orbicularis oculi, the pretarsal injection, that is around the eyelids, that is preferred, and that has shown improved results than the preseptal injections. The doses are very small, 1 to 5 units in different muscles, and adverse effect, if happens, like ptosis, facial weakness, these are transient and these improve over some weeks. However, the Botox treatments is required every 3 to 6 months. The microvascular decompression is the definite treatment for hemifacial spasm, and that this can lead to permanent cure of the condition. And what you are seeing here in the first picture is a vessel which is compressing and indenting the seventh nerve. And in the second picture, you are seeing a Teflon sponge being interposed between the vessel and the seventh nerve. And this typically relieves the pressure from the seventh nerve, and that leads to cure of the condition. So there can be two ways of doing MVD. One is the interposition of the any graft like Teflon, muscle patch, G patch, or anything. And second is the transposition of the vessels away from the nerve and fixing it to any nearby dura or tent with fibrin glue. This procedure is very effective. It leads to about 85% of patients having complete resolution and 16% showing good improvement. There are features which predicts good outcome with the surgery, like male gender, mild hemifacial spasm, presence of indentation of the facial nerve, especially in the preoperative MRI. And whenever there is delayed reversible facial palsies, these are good predictors of permanent cure. The adverse effects can be there with the surgery, like hearing loss and permanent facial nerve palsy, but with the precise, meticulous microscopic techniques, this is very rare. If you utilize the endoscope, that improves the efficacy by preventing the leaving of any neurovascular conflict. You can see the conflict until the bone from which the facial nerve goes out. And the endoscopic guidance thus reduces the adverse effects also by good magnification and visualization. Intraoperative neuromonitoring is very helpful in this surgery. You can utilize this by two ways. One is direct stimulation of the facial nerve at the CP angle, and you see triggered EMG activities in the different facial muscles. So this helps to identify firstly the seventh nerve. What you are dealing with is actually seventh nerve, not eighth nerve, and you are removing the neurovascular conflict from it. And then secondly, in the second picture, as you're seeing the recording of the seeing the evolution of lateral spread responses. What does that mean? This means that there is ephaptic transmission. If you stimulate the temporalis nerve, which is found midway between the lateral margin of the eye and tragus, if you stimulate the temporalis branch of facial nerve, You may see delayed responses in frontalis, orbicularis oculi, oris, or mentalis. So this can be seen in the preoperative period also and during intraoperative pre-MVD period also. And when you see the lateral spread responses and in the pre-MVD and after MVD, you see abolition of lateral spread responses like it is seen in the mentalis muscle here, and you see abolition of LSR here. There is a good chance that there will be early result uh, after your surgery, that your neurovascular conflicts has actually gone out and there is no any other leftover neurovascular conflicts. So if there is a persistence of lateral spread responses, that means you should still search for more neurovascular conflicts. There can be there, and you should take out that. So however, the lateral spread responses, visualization and interpretation and seeing its abolition is not very easy. That requires practice, and and there can be multiple situations in which you will have difficulty in interpreting LSRs. Like there is presence of muscle relaxants during anesthesia. The patients who have received multiple Botox injections prior to the surgery, they have inconsistent responses. And another important thing with the LSR is you can follow up these patients. Suppose you have persistence LSR during the surgery and the patient is having hemifacial spasm. So you can follow up these patients in a few months, in 2 to 3 months. In suppose LSR still persist after three months of surgery, that means your the neurovascular conflict is maybe there, and you may opt for going for resurgery. Lastly, few points about blepharospasms and Meige syndrome. As I said, blepharospasm is spasms bilaterally of both the eyes. And when it's associated with the oromandibular dystonia, it's known as Meige syndrome. So again, in this, Botox is the initial treatment. However, if the Botox is not effective, you can go for myectomy. The risk outweigh the benefits. So in these patients, deep brain stimulation of the globus pallidus can be offered. This has shown in multiple case reports to be very effective. You can also go for a bilateral pallidotomy in staged manner for Meige syndrome. So to summarize, hemifacial spasms are paroxysmal, involuntary, and involves unilateral twitching of face. The hemifacial spasms gets precipitated by doing sustained voluntary contractions. It usually begins around the eye. The eyebrow moves up, which is known as other Babinski sign. EMG helps in excluding the differentials of hemifacial spasm. Botox and MVD are the treatments for HFS, and both of these are very effective. Intraoperative neuromonitoring is very helpful in MVD surgery. Blepharospasms, Meige syndromes can be offered pallidal DBS or lesioning if the Botox is ineffective or when the patient wants it. Thank you for attention. If you have any questions, you can type in comment section, and please subscribe to the channel. Thank you.